Hey, hi all. So as you know that if a person has to undergo surgery, the very first step is to go to an anesthesiologist and get the pre-anesthetic evaluation or the checkup done. Now the whole point is why at all a patient requires to go there. He may come to the OT directly to and get his surgery done. But the point is if he doesn't get pre-anesthetic evaluation, the diseases, the comorbidities that he has will not be optimized. The time we can use to optimize them first and then take up them for the surgery to reduce the morbidity and mortality of the patient is the major reason why we conduct pre-anesthetic evaluation. The second thing, we this is the first contact of the patient with the doctor. So this will build the anesthetic rapport with the patient, and his anxiety will reduce drastically. He'll be able to understand what surgery he's going to undergo, what all risks are associated with the surgery, and he'll also plan what whether he want to undergo that surgery or not, depending on the urgency. In the end, he'll be able to give consent for the surgery to undergo that particular procedure. This was the reason why pre-anesthetic evaluation is important. Now, this pre-operative evaluation starts with the demography or the details of the patient, which will tell you whether the patient is a male or a female, elderly or a child. So the very first step will let you know what type of diagnosis you are dealing with, what type of surgery the patient is going to undergo, because the person has already underwent evaluation from the surgeon side, so he must have investigated and taken the history for the patient, and almost all the times we have a confirmed diagnosis and a confirmed plan of surgery is also mentioned on the OPD sheets of the surgeons. So we'll have this will help us to understand what type of anesthesia we are going to be dealing with, and that will uh, impact what type of history and examination you'll be focusing on. So the first, for example, if it is a hernia surgery and you know that patient doesn't have any comorbidity, and you evaluate the patient, and finally you'll realize that this is a surgery which has to be undergo with a neuraxial blockade, preferably. Obviously a failed neuraxial will always undergo general anesthesia, but if it is primarily an uncomplicated patient and a neuraxial anesthesia, it is obvious that in the examination you will be focusing on the spine of the patient. All right, the neurological component of the patient, the CNS examination, they will impact a lot, because you're going to give a neuraxial blockade, which otherwise would if suppose a surgery is for the upper limb and you want to give a peripheral nerve block itself in an uncomplicated patient, so the importance or the chances that you'll be dealing with medical legal problems of a spine problem will be less, because the surgery or the intervention that we are doing is not on the spine. So this is how you'll have to understand that the first details of the demography and the type of surgery is the beginning step to understand what type of anesthesia we're going to give. Then we'll ask the relevant history, what comorbidities the patient has. The airway examination is something which is different from the general physical and systemic examination that we usually do in our medicine. So in the undergraduate period, we have already learned about how to conduct a general physical examination, systemic examination. So depending on the surgery and the type of patient, we have to focus on a particular system more importantly. But airway is something which we as an anesthesiologist have to be perfect in. So this one topic will have to be read in detail and understood carefully. Now, once we have done with the examination and history and we know the surgery, so we have to ask for relevant investigations. What do you mean by relevant? We'll understand in this video. Then the plan of anesthesia has to be made, and based on that we'll be giving pre-op orders and optimize if at all there is some comorbidity. Then ultimately the patient will give the consent and will proceed to the intra-op period. So with this overview, what happens in the pre-op area, These four topics must be known to anesthesiologist in detail, that is airway assessment, the ASA, that is American Society of Anesthesiologists physical status classification, pre-medication, and the pre-op orders, that is what medications to continue and what to stop. These are the topics which cannot be discussed as such in this short video, because they itself are a diverse segment. So we'll begin with the pre-operative sheets of RML hospital, and you have to understand that every hospital or a nursing home or whatever that is, it has their own sheets, and there are certain good points and certain bad points for individual hospitals. So we are focusing right now on RML, and you have to understand that the important points remain important, and based on what sheets or booklet you have in your hospital, you can change your plan. We'll start with the demography. You can see that I'll mark it. This the name, this is the identification number, diagnosis, and the surgery planned. Then we'll ask for the height, weight, BMI. This will make us realize that if the patient is obese, then we have to ask for a questionnaire which is known as Stop Bang questionnaire. STOPBANG. What do you mean by Stop Bang? Is this is a questionnaire to rule out obstructive sleep apnea. If it is more than 5, because if you add on the score, if it is more than 5, there are high chances that there will be post-op complications and high chances of airway compromise in the patient post-op. So you have to understand that in the pre-op itself, you have to evaluate whether it is a high-risk case for OSA or it is not. Then in the next part, we'll ask for allergies, like the drugs, food, dust, pollen, or egg, latex. Then we come on to the airway, which we'll understand in detail in some other video. But the very important thing that you should remember, why at all are we conducting airway examination? This is to rule out the predictors of difficult airway. Right, that predictors of difficult airway can be found out based on history or examination. Now, what do you exactly mean by a difficult airway? Difficult airway, according to the ASA, it includes the clinical situation in which anticipated or unanticipated difficulty or failure is experienced by a physician trained in anesthesia care, including but not limiting to these following factors, that is face mask ventilation, laryngoscopy, supraglottic airway, intubation, extubation, or invasive airway. So that this is exactly the sequence that we have to a person has to undergo, starting from the face mask ventilation till if it is cannot intubate, cannot ventilate situation, that then have to undergo invasive airway. So every single step, if there is a difficulty, whether anticipated or unanticipated, is difficult. Now I have a mnemonic for all of these individual difficulties, and this is something that a person as an anesthesiologist has to remember lifetime. For the bag mask ventilation, there's a mnemonic called MOANS, MOANS. There's another mnemonic called BONES, which is very similar to MOANS. What are the components? If there is a difficulty in the mask seal, if there is some obstruction in the airway, the patient is obese, if the age, if they are elderly, and then if there is edentulous patient because there will be leak around the mask, and if the person has less compliant lungs, that is stiff lungs, or again because of obesity, if they have pulmonary hypertension and their lung fibrosis because of sleep apnea, all those components will be increasing the resistance to the airflow. So that resistance will lead to more of the leakage around the bag mask. These are, so you have to remember and for this lifetime. The second component is supraglottic airway devices. The mnemonic is RODS, RODS. that is restricted mouth opening. Because if the mouth opening is restricted, how will you insert a supraglottic airway device, right? Then again, obstruction, any distorted anatomy, because if there is some distorted anatomy, if even if you insert a supraglottic device, there will be leak, and again the stiff lungs. Then we come on to the laryngoscopy. The mnemonic is lemon, Lemon. So you have to look externally. What do you mean by look externally? When we'll do the airway assessment, there are certain characteristics like retrognathia, if there is some facial trauma. So yeah, on looking externally, you'll be able to realize that this is a difficult laryngoscopy. Then we have a rule 332 evaluation. This will understand in airway assessment that there are certain distances that if you measure, then you will be able to understand if it is a difficult or easy laryngoscopy. Then we have Malampatti, or known to all of you. And again, obstruction, obesity leads to difficult laryngoscopy. And if there is limited neck mobility, if the patient is not able to flex or extend his neck, the range of motion is limited, then, because as you all know that for intubation we need a sniffing position, and you will not be able to attain that position because of the restricted neck mobility. So these are the factors for difficult laryngoscopy. The last one is difficult front of neck access. If you are not able to intubate and ventilate the patient, you may have to go for the FONA. The mnemonic for this is SMART, SMART. So if there is some surgery, a person has undergone any neck surgery, neck dissection or something, any mass is present like thyroid mass, and if there is difficult in the assessing the anatomy, if there is some radiation exposure, and if there is some tumor, so these lead to difficult front of neck access. So these are the predictors that everyone should remember. We'll discuss the airway assessment as such in by demonstrating it on a volunteer in some other video. Moving on forward, there's just general physical examination, which is very simple as you must have done in undergraduation. Then there's this nutrition, where the patient is frail, obese, average or malnourished, and IV access, which is important to us, because if there's difficult IV access, then there's a possibility that you have to search for a central venous access. You have to understand it in pre-operative period, operative evaluation itself. Next, we come on to the systemic examination. Respiratory and cardiovascular system being the most important to anesthesiologists, because whatever drugs that we are going to give, they are mostly 99% they are cardiodepressant. So whatever we give, they have an impact on the cardiovascular system. So we should know about this, and respiratory because we are dealing with airway. Rest of the examinations, whether it is CNS examination, GIT, renal, endocrine, musculoskeletal, will depend on what type of case we are dealing with. For example, if the patient is a seizure disorder, you have to evaluate the neurological system. If there's some neurosurgery, then you have to evaluate CNS in much more detail. If there is involvement of cranial nerves, because that will impact our gag reflex, that will lead to aspiration. So based on that, these systems have to be evaluated in further detail. That will depend on individual cases. After the examination, there is certain negative history that we have to ask, and in the laboratory studies, that is the investigations, they have to be relevant. Now what do you mean by relevant? I'll tell you that there are investigations which are to diagnose a disease, which usually a surgeon does. And as an anesthesiologist, if barring the practical examinations where they are asking you the differential diagnosis for a disease, and in practical life we already have a diagnosed patient, we already know what type of surgery he has to undergo. So this investigations we are not usually dealing with. So we have to ask specifically the investigations which will impact our anesthetic management, which will tell you whether there some complications may occur in intra-op period, whether something may happen in the post-op period. So this management for individually for that particular patient we have to ask. This chart is given by the ISA, Indian Society of Anesthesiologists Practice Guidelines, which says that not all investigations are required for all the patients. If you look at this table, it is mentioned that for a minor surgery, only CBC and a 12 lead ECG is required, and 12 lead ECG also only if the patient is more than 45 years of age. That means if you have a young patient who is non-diabetic, ASA 1 patient, I'll tell you what is ASA 1 or 2 patient, and has to go elective surgery, not the emergency surgery, and he is not 45 more than 45 years of age, then only CBC is sufficient. You don't have to subject the patient for a chest x-ray or the LFTs or KFTs or whatever. So those additional investigations that we usually find in our files are not necessary for every patient. This video is to make you aware that only after a certain age a ECG or X-ray is required. As you can see in the next step, the intermediate surgery, we have to ask for CBC, serum creatinine, 12 lead ECG for patients more than 45 years, chest X-ray for more than 50 years, right? Similarly, you can see here, intermediate surgery more than 45 years is ECG, more than 50 years is X-ray. For major surgery, whatever major surgery, you always have to ask for ECG and X-ray if it is more than 50 years of age. Now you may ask that a patient has investigations which are much older. How do you decide whether the investigations have to be repeated? So this is the guideline that for CBC it is 2 months, for renal functions 2 months, LFTs 2 months, ECG 12 months, and X-ray 12 months. Now obviously if the symptoms have deteriorated or the symptoms have changed or a new symptom has arisen, then you may ask for any investigation, repeat investigation. This is the list for what is known as a low risk, intermediate risk, or a high risk surgery. You can take a screenshot for the same. Once we are done with the investigations part, you have done the history examination, you have asked for the investigations, then you have to assess based on all this what type of patient we are dealing with. That means what ASA status we are dealing with. What do you mean by ASA status is that we should be able to assess and communicate the patient's pre-anesthetic comorbidities among us. If someone says ASA 1, you should be able to understand what type of patient it is, how much risk of morbidity and mortality is there. And similarly, if it is ASA 3 or 4, you should be more cautious. You should be preparing your OT, you should be preparing yourself and for the intra-op and post-op complications. So this the advantage that it is easy to use, but the disadvantage is it does not include pre-op optimization. It does not include what type of surgery the patient is undergoing, doesn't include what type of post-op care is available to us, and it is very subjective. Suppose if I consider a patient as ASA 2, some other person may ask that the person is ASA 3. Because this is a subjective evaluation, it is not objective, and it does not include neonates and a very old age patients. So these are the disadvantages of ASA being a very vast topic, because there are a plethora of examples within each category, but this is the most concise thing, that ASA 1 patients are a normal healthy patients. ASA 2 patients, they are having mild systemic diseases without substantive functional limitations. ASA 3 are having severe disease, but they are usually well controlled. ASA 4, they are having severe disease and they are having a constant threat to the life. ASA 5 is a moribund patient who is not expected to survive without the surgery. And ASA 6 is actually a brain dead patient. And usually brain dead patients are taken for organ retrieval. So these are the categories you should have to classify. You should classify every patient into these categories to communicate among your colleagues what type of patient you are dealing with. Once we are done with ASA patient classification, then we'll do the optimization of the patient, we'll plan, and we'll give the pre-op orders. In the pre-op orders, you have to, first thing is you have to see what all medications the patient is on. You have to stop certain medication and you have to continue certain medications. You have to give nil per oral advice, 6 hours for solids, 2 hours for clear fluids, which is usually like water or black coffee or tea, not the juices which are having pulp, right? If it is breast milk, it is 4 hours. If it is a non-human milk, it is again 6 hours. Then after the NPO, you will give you'll ask for a written informed consent. If it is a high risk case of surgery, then you have to ask additionally a high risk consent. Now, depending on the case, there are certain things that you can look out for pre-op optimization. It is antacids, anti-anxiety, anti-sialagogue, analgesic, nebulization or incentive spirometry, whether a patient require blood pre-operatively, any specific requirements or anticipated post-op care, whether the patient may require HDU or ICU post surgery. Among these, the antacids usually ranitidine, Rantac is not given. It is having teratogenic, carcinogenic and teratogenic capacity. So because of the carcinogen, we are not giving or preferring ranitidine. Even Pantop is not preferred as such. So we are giving injection metoclopramide 10 mg in the preoperative area. Then for anti-anxiety, very often we are giving the tablet alprazolam 0.25 or 0.5 mg on the night before surgery. For the anti-sialagogue, for certain surgeries that may be required in the pre-op period, usually suppose it is awake fiber optic intubation, so we give injection glycopyrrolate intramuscular 0.2 mg to prevent the secretions. Similarly, for cases like we are giving ketamine, so we can pre-medicate it with analgesic. So you have to understand pre-medication is different from pre-treatment. Pre-treatment is usually given just before the surgery, half an hour or 1 hour before the surgery. Pre-medication is usually given a night before. So usually it is 12 to 24 hours prior to the surgery. And the rest of the things which I mentioned is for the optimization of the patient. This constitutes the primary pre-anesthetic evaluation. Not all the patients will have the constant disease progression for their comorbidities or the surgical point. So we do require a review PAC 1 day before the surgery, which will tell you the exact situation prior to the surgery and if certain new investigations or certain other optimization need to be conducted. Once the patient is fit for the review PAC, then on the day we'll take an informed consent, which will mention what type of anesthesia you are planning to give, whether it is a general anesthesia, spinal or epidural, nerve block with regional, monitored anesthesia care, and similarly a high-risk consent for specific high-risk surgeries. So this is all about the pre-anesthetic evaluation, and any doubts may be commented below in the video section. Thank you so much.